Thank you very much. Okay, so I am following 3 absolutely wonderful talks with some great videos and stuff, and now it is my task to make adrenaline sound interesting. So, good, comic relief. So, all right, so adrenaline's been around, obviously, for a long time, and I can't quite see, but show of hands of Americans real quickly in the room. Anybody? Okay, just a few, good. You're the ones who will forgive me if I say epinephrine, right? Okay, because I'll try to make sure that I say adrenaline, but since we're here. So, adrenaline and cardiac arrest, rethinking it. Now, I guess I first want to start with, how did we get here? I mean, how did we get to where we use adrenaline all the time? We've been using it for over 60 years in cardiac arrest. It's part of the air we breathe as resuscitationists. So, how did we get here? Well, I'm going to start by first just planting an idea in your mind, which is that I think the Achilles heel of resuscitation, for all of the years that we've been trying to resuscitate cardiac arrest patients, has been the fact that we do not do well, or we have not done well, with the problem of artificial perfusion. We can ventilate very well, our defibrillators work very well, but the problem that we have is when we're doing chest compressions, we don't generate, in too many instances, enough blood flow to actually get return of spontaneous circulation and have patients survive. So this is our Achilles heel. And it applies to this question of adrenaline. So, the whole ball got rolling really in 1960 when the researchers at Johns Hopkins University described closed chest cardiac massage. CPR was born. Peter Safar added put that together with positive pressure ventilation, mouth to mouth, or bag mask ventilation, and we had CPR. That was born in 1960, 1962. That's when it came along. So since then, we've been trying to teach this to everybody. We all know the history of how this is now part of what we do. It is a big reason why we are here as resuscitationists. If you do this, all of us as emergency physicians, critical care, paramedics, whatever, we do this. So, okay, well, how did adrenaline actually get into the mix? And I propose, our session here is on kickstarting the heart, and well, the adrenaline was the idea of, well, we want to try to help kickstart the heart along with doing these chest compressions. It was clear that the chest compressions apparently weren't, perfect, and so a number of researchers started to look at how can we actually improve on this? What drugs can we give that will actually help with this process? And that's how adrenaline got into the mix. There were a bunch of laboratory studies done that looked at various drugs, including like isoproterenol or isoprenaline, depending on what you're used to, epinephrine or adrenaline. And what really came out of it was that the study showed that of the drugs, several of them sort of worked, but adrenaline seemed to work the best. And this was in laboratory animal models. So, and then when it came to extrapolating and beginning to use this anecdotally in humans, there were various drug dosages that were recommended. One person was recommending as little as 0.1 milligrams of adrenaline, some as much as 5 milligrams of adrenaline. That seemed so high that they thought it was a printing error in this particular review. But how many of you ever kind of wondered, where did we get that 0.01 milligrams per kilogram of adrenaline that we use? Roughly 1 milligram for an average adult, and that's what's been promulgated. We didn't have research that did a dose-response curve to show that we should use 0.01 milligrams per kilogram. As a matter of fact, I think the literature on this is basically what you're looking at right here. A milligram had been used in laboratory studies, and anecdotally, a milligram was used in adults, and it looked like it worked. So, and you might need to use more than one dose. There's the evidence for a milligram of adrenaline that has been promulgated through the protocols for the last 60 years. That's where it came from. We really have never gone back. And again, it became part of the air we breathe in resuscitation, so it really didn't get questioned. And of course, it's now part of ACLS. As a matter of fact, if you look at all the ACLS things that we do, the flagship drug really for ACLS is adrenaline. That's what we give. We give it, routinely. It's the go-to drug for all forms of cardiac arrest. It's the thing we give most consistently in everything. So it's really one of the key things we do in ACLS. But why? The reason that we give adrenaline in cardiac arrest, and you probably already know this, is that we are trying to actually help improve that artificial perfusion that I was mentioning before. When we're doing chest compressions, we only have a limited amount of blood flow. We are trying to improve that blood flow. And the way we do that, and the mechanism by which it works, is by increasing the coronary perfusion pressure. And just quick review, that coronary perfusion pressure is the aortic pressure at the outlet, at the beginning of the coronary arteries, all the way to the right atrium where the coronary sinus is. So it's the pressure gradient across the vasculature of the myocardium. That's what we're trying to influence. We're trying to raise that pressure gradient so that the simple physics of flow will increase the blood flow to the heart during cardiac arrest, giving us a better chance of getting return of spontaneous circulation. That's the whole reason for doing this. We have seen from other studies that, and this has been shown both in laboratory and in clinical trials, that you need to have a coronary perfusion pressure of greater than 15 millimeters of mercury in order to get return of spontaneous circulation. And not just 15, the higher the better. If you can get to 30, 40, the higher you go, the better the chances of getting return to circulation. Or if you just have aortic pressure, you want to get that CPR diastolic aortic pressure above about 30 millimeters of mercury so that you have a good coronary perfusion pressure. And so why we give adrenaline in cardiac arrest is to try to manipulate that coronary perfusion pressure. What happens is when you give the adrenaline, you circulate it, hopefully, and then you get peripheral vasoconstriction in the arteries. By increasing the peripheral arterial vasoconstriction, you raise the aortic pressure, you raise the coronary perfusion pressure gradient. That's the reason we do it. Originally, the thought was give the adrenaline in order to really kick the heart, get the heart going again. We know it's an inotrope, we know it's a chronotrope, but really what turned out to be in the science is we found out that in cardiac arrest, the real benefit of adrenaline is the peripheral arterial vasoconstriction. Okay, so this is what it looks like if you're doing CPR on a human. And this is an arterial pressure tracing. You can see that you can generate high pressures, and you're looking at, really at the diastolic. It's the bottom of this that you're really interested in when you're trying to improve cardiac arrest blood flow. This is it right here, this diastolic pressure, because this is where most of the blood flow occurs during CPR. This is what it looks like. I've cut off the top of it so I can accentuate it some, but this is an arterial pressure tracing in a human. This is the right atrial pressure tracing. You see, this is the gradient. This is the coronary perfusion pressure gradient. And you can kind of look over here and see from the scale that this is a coronary perfusion pressure of about 30 millimeters of mercury in this patient, which is a good coronary perfusion pressure. And about 2 minutes after this, when this patient was shocked, this patient had return of spontaneous circulation. So that's what we're aiming for. And the adrenaline is there to try to maximize this gradient. So we have over 60 years of clinical experience plus an enormous amount of laboratory data that has looked at the use of adrenaline in cardiac arrest. So, but is there really a benefit? And this is a big question right now because there really are serious questions about, are we really getting anywhere? Because if you look across the history of resuscitation, for the most part, we have still been suffering with poor survival rates. They've been very, very disappointing. And it doesn't appear that adrenaline has really dramatically changed this. And even though we got anecdotal appearances that seem to maybe have done something to help us get return to circulation, does it really improve survival? Does it really lead to long-term survival with good neurologic outcome? And that's a big question. But again, it was in the air we breathe. We're using it. Nobody could say we're going to actually, at least for a number of years, nobody would think to themselves, look, we're just going to actually stop using it, or we're going to test it against placebo and actually see if the adrenaline is doing anything useful at all. It was just too much part of what we did. It was thought to be unethical to even think about doing a study where you didn't give adrenaline. However, high-dose adrenaline came along. Now, I'm guessing that a number of you in this room still remember high-dose adrenaline, right? Is that, you don't have lights, but I'll show a hand, something. You probably remember high-dose adrenaline, but that's sort of come and gone. And the reason that sort of came and went was that we actually kind of came to the realization that it didn't really benefit the long-term outcome. We had some increases in return circulation, increases in hospital admission, but long-term discharge survival and neurologic outcome were not improved with high-dose adrenaline. And so so it basically came and went. It was gone. But standard dose adrenaline stayed around. It's still there. Why? I mean, because it's the air we breathe, right? It's been around forever. It's the way we do things. But now the question's begun to come along. Well, maybe that's not the case. So there's actually, for all the studies that I'm going to show you, some studies that are showing standard dose versus high dose epinephrine, or adrenaline, there we go, and showed that there's no difference. But there's very little on data of standard dose adrenaline, what we typically do, versus placebo, not giving adrenaline at all. But one study was done, it was published in 2011, and this is it. Now, the data is a little bit small, but fundamentally, the conclusions at the bottom is that, yes, indeed, as we sort of observationally or anecdotally thought, you do get some increase in return of spontaneous circulation. It does seem to help you get there, and it helps you get patients to the hospital and get them admitted. However, there's no difference when you look at placebo versus standard dose adrenaline at hospital discharge and long-term neurologic outcome. So even though it helps us get them in the hospital, it doesn't help us get them out. And that's the problem. But this is really the only randomized study right now that we have. There's one that's ongoing or getting started in England that's going to help us answer this question further. In the last few years, this question of whether adrenaline is useful or not has led to a series of meta-analyses of all the data, all the clinical data that exists on adrenaline. Now, there are about 5 or 6 of these, and frankly, I'm just going to show you some data from one of them because they all are pretty much variations on the same thing. They all pretty much show the same thing. So I'm just going to show you this one, some data from this. It has some nice graphics in it. So let's first look at, now first I would show you data on standard dose versus placebo, except I've only shown you the only study that was actually in there, and that showed the results that you get increased return of circulation and admission, but not long-term outcome. If you look at the studies that looked at standard dose versus high dose adrenaline, and there were a series of these that they could actually analyze, you can see that, well, if you look at just for return of spontaneous circulation, it does appear that, well, there's at least some leaning towards saying that there's some improvement in return of spontaneous circulation with high dose adrenaline compared to standard dose adrenaline. And there were 3 studies that came out in 1992 that were actually presented at the American Heart Association meeting before they were even published that led to that initial acceptance of possibly using high-dose adrenaline in cardiac arrest. That's where it came from. Now, admission rate, same thing. You can see that there's, at least, it appears that with high-dose adrenaline that you had some increase in the number of patients that made it to the hospital and actually made it to the admission process. However, once again, and this is just like what happened with standard dose adrenaline versus placebo, is if you look at hospital discharge, no improvement at all, meta-analysis of all the data that exists. And of course, unfortunately, when you look at neurological outcome as well, no difference, or even maybe there was just almost a hint that it was worse. So no difference really in terms of discharge from the hospital and neurologic outcome. And so high-dose adrenaline went away. And this just basically is a review of that. So moving along. Okay, so we have what I would say is sort of this adrenaline dilemma in cardiac arrest. Why is it not working? And I'm going to try to offer to you a rationale for why I think adrenaline is not working for us in cardiac arrest. It's because we give it intravenously. Okay, and you're saying, well, wait a minute, that's how we give drugs. I mean, that's how we give drugs during cardiac arrest, right? When you think about it, when we give drugs for anything, we give them intravenously with the intent that they be circulated to effector sites somewhere else, generally in an arterial supply somewhere, whether it's morphine or antibiotics or whatever. We don't push those medications into the veins to have them sit there. We intend for them to be circulated. Well, the only situation we're in where we actually have a low-flow, no-flow state like this is cardiac arrest. And at that point, what we're trying to do is get the heart started again. So the same problem here is that IV drugs, giving drugs intravenously, or especially adrenaline in cardiac arrest, is not going to be effective. Now, this, I think, is really the crux of my talk here. This is it. This is the dilemma. I've tried to sort of give you some sense of what it is. We give adrenaline again so that we can get peripheral arterial vasoconstriction, so that we can raise the aortic pressure, raise the coronary perfusion pressure, and improve the blood flow during CPR, right? To lead to return of spontaneous circulation. That's the reason we give adrenaline. Now, if you have a patient that has really poor coronary perfusion pressure, and these are rough ideas, I'm just giving you sort of rough notes, but if you have a coronary perfusion pressure, if you're measuring it, and it's less than about 8 to 10 millimeters of mercury, if you give intravenous adrenaline, that adrenaline is basically going to sit in your veins, and very little of it, if any, hardly, is going to be circulated to the arterial side so that you get an effect. That's the problem. On the other hand, if you have a patient that has really good coronary perfusion pressure, and again, how are you going to know this unless you're measuring it? If you have really, really good coronary perfusion pressure, like over 30 millimeters of mercury, you may not need adrenaline because you're probably going to get enough blood flow with a little bit of time to actually allow you to get return of spontaneous circulation with, say, defibrillation, or the heart's going to kick in, it's going to begin to beat again. So these are patients that really, may not need adrenaline at all, and it may actually be detrimental. Because if you think about the dosages of adrenaline that we give, when we're giving a milligram, now what do you think would happen to any of us right now if somebody gave us a milligram of adrenaline intravenously at this moment? Some of us, probably me, would have a cardiac arrest. That's a lot of adrenaline. As a matter of fact, when it first came out, there were people who said, wait a minute, we can't give a milligram of adrenaline. That's a whopping huge dose. It's too high. So the problem is that the patients that need the adrenaline the most, if you give it intravenously, you can't get it where it needs to go. You can't get it to a place where it's actually going to have the vasoconstrictor effect. And those that have really, really good coronary perfusion pressure, well, they may not need it at all. It may be detrimental. It's this borderline area in here. And again, we don't know who this patient is unless you're measuring the coronary perfusion pressure. These that are in the middle here that may have some flow may benefit from adrenaline to raise that coronary perfusion pressure because you are able to get some of it circulated to their peripheral arterial system. And this may be beneficial. But in the process of doing so, if you've given several doses of adrenaline, you may wind up getting return of spontaneous circulation and then may basically have an overdose. I think this is what happened. This is why high-dose epinephrine at least showed some promise. It appears that probably what happened was that if you're in a low-flow state and you push 10 milligrams of adrenaline into the intravenous system and you mobilize and you manage to circulate 1 milligram of it and get a vasoconstrictor effect, improve your coronary perfusion pressure, get return of spontaneous circulation, well, good. Except that what do you do then? You then mobilize the other 9 milligrams of overdose that your body did not need. And an overdose is an overdose. We know that there are adverse effects, and I think that's what happened. We would mobilize this overdose of adrenaline, and these patients would go on to die in the refractory in the intensive care unit. So I think this is why a high-dose adrenaline that appeared to be better in terms of return of circulation than standard dose epinephrine, why it didn't work because of the overdose. Well, the problem with standard dose over placebo is, sort of the same sort of things. We can't circulate. I mean, it's a circulation issue. It's actually getting the drug to where you need it. So the question is should we actually abandon adrenaline completely in cardiac arrest? And there's really, you could argue that there's not sound evidence for using it, so you could say, well, maybe we should just stop using it. But I would just say, well, maybe you're not just yet. Maybe the question is, maybe we need to, when we're rethinking adrenaline, maybe it's not rethinking adrenaline, do we use it, do we not, but maybe it's rethinking adrenaline in terms of how we give it, okay? So we give it intravenously, it's what we've always done, but if it's not effective because we're not circulating to where it needs to be, then maybe what we should be doing is putting in arterial lines, intra-aortic lines, and titrating in doses of intra-aortic epinephrine in order to try to resuscitate somebody. Okay, and is this sounding a little far-fetched to people? I hope not. When I first started talking about doing this, it would really seem far-fetched, but we're talking about the days of doing Roboa in the field, ECMO in the field. This isn't quite so far-fetched anymore, but this may be one of the ways that we can actually try to impact on this. I got interested in the idea of intra-aortic adrenaline while working on this technique that I've worked on for some years. And I won't talk about it anymore because this is an adrenaline talk. But what I did was, I found that it seemed to be beneficial in some of my research, so I actually did just a specific study on just intra-aortic adrenaline versus central venous adrenaline, which is the best way you can give it. And what I found was that it clearly works better if you give it intra-aortic, especially if you dilute it up, push it into the central aorta, diluted, push it out into the periphery. What you see is a dramatic and very rapid adrenaline effect. Here, you can see this is right where it's given, and here you can see they're plateauing. This is the change in aortic pressure, and you can see that out here, within somewhere between about 30 and 50 seconds, you have the response to the adrenaline that you want to see. I mean, you're going to see what the effect of that dose is. And because you have an aortic catheter in place, guess what? It also allows you to measure the pressure, see what's going on, and titrate your care. So you get two things out of putting in an arterial cannula or an intra-aortic cannula. You can measure the pressure to change your CPR and optimize your CPR based on a pressure that means something, and it gives you a route for giving adrenaline in a very effective way. And you can give small doses, see what the effect is over 30 to 50 seconds, and then you can titrate rapidly to effect so that you give the dose of adrenaline that you need and want without giving an overdose, and you're giving it effectively. So this one study, one of the things I found, if you maybe have seen it from that first study, they splay out. I mean, all of the coronary perfusion pressure is relatively similar in these experiments, and then they splay out quite a bit. Well, one of the things they found was that the response to adrenaline that you wound up getting was predicted by what your coronary perfusion pressure was in the first place. And this is, again, something you're not going to know unless you're actually measuring the pressure. You can't tell when you're doing chest compressions whether your coronary perfusion pressure is 50 or 5. There's just no way to know. I mean, you can do end-tidal CO2, and that may be a viable way of giving you some sense of it. But you really don't know what that coronary perfusion pressure is unless you're actually measuring it. And so you don't really have a good idea of just how much adrenaline you need to actually get the physiologic effect you want and help you get the patient back. This is another example of it where I did serial doses of intra-aortic adrenaline versus intravenous adrenaline. And here again, you can see that over time, you can actually begin to get an effect with the IV adrenaline, but you get a robust, rapid effect with the intra-aortic adrenaline consistently, serially. Over every 3 minutes, you get this. So the response to intra-aortic adrenaline is clearly better than to intravenous adrenaline. And that may be helpful in allowing us, but if we do it this way, if we gave it this way, maybe we would actually see some benefits of adrenaline without a lot of the adverse effects that we seem to be regularly seeing. Now, how far-fetched is this? Well, the idea of putting in intra-aortic catheters is really not that far-fetched. I did it in an emergency department for a long time. We actually set up a system where we went into the field and we're putting in thoracic aortic and central venous pressure catheters in the field, in field cardiac arrests, and changing the CPR to maximize the coronary perfusion pressure, rate, depth of compression, everything. We changed our CPR to maximize the coronary perfusion pressure, and we titrated in doses of intra-aortic adrenaline in order to maximize that coronary perfusion pressure. And when I went into the field doing this in humans, I started with a 1/4 milligram. Not a milligram, I started with a 1/4 milligram because I knew that I was probably going to get a more robust effect than what you would ever see intravenously. And in fact, we had some patients that actually responded incredibly well and only required 1/4 milligram of adrenaline to get the therapeutic effect and get return of spontaneous circulation. So you can rapidly titrate the dose of adrenaline that you need to get return of spontaneous circulation to help you, but not to overdose them and potentially make them refractory to further therapy. So you get the benefit without the toxicity potentially. And this is just to show, these are the catheters. We take them into the field. We would actually, all you need is just simple pressure catheters. Long pressure catheter will get up into the aorta is all that you need. And I was doing this in the field, which means that you could do it in the field. I even think we could train paramedics clearly to do something like this. It's simple vascular access technique, slip in an arterial cannula, measure the pressure, give intra-aortic adrenaline. I think it would work. This is just showing you how we put it in. Femoral, do a simple measurement up into the thoracic aorta, and you're good. This is what it looks like. I showed you this slide earlier. This is one of the patients that I was actually monitoring in the field. This was a pre-hospital cardiac arrest who was cannulated in the field to measure coronary perfusion pressure and had return of spontaneous circulation. So, just to kind of sum it up, in rethinking adrenaline, okay, intravenous adrenaline does improve return of spontaneous circulation. It does improve hospital admission. But so far, we have no evidence to suggest that it actually improves hospital discharge and neurological outcome, which in the end, that's the critical thing. On the other hand, return of spontaneous circulation and admission to the hospital are prerequisites for being discharged from the hospital neurologically intact. So we do have a bit of this dilemma. And I think the question is, if we're not going to give IV adrenaline anymore, then what are we going to do in its place in order to try to help us resuscitate our patients? And I would say that we are now moving into this endovascular, we're clearly in it, it's in the early stages, into this endovascular, extracorporeal perfusion, resuscitation era. It's here. I think it's staying. And the question is that, are we going to move to, well, went the wrong way. Okay. are we going to say, in some instances, if you have the capability of actually rapidly getting somebody on extracorporeal life support, that sounds like the way to go to me. I'm a fan of that. I think that's great. But if you can't do that quickly, what can you potentially do quickly or do in the pre-hospital setting to help bridge your patient to survival and help them get to a center where they can get something like that? And that's where putting in aortic catheters, intra-aortic adrenaline might work, or extracorporeal perfusion, in which case, if you've got great perfusion, you may not need adrenaline at all. We'll figure that out as we get further into this era. And I'm done. Thank you very much.
Well, thank you, Jim, very much. I think in the context of what we've been hearing about today, I think I heard this talk, or a version of it a couple of years ago, and thought, oh, I'm not so sure about intra-aortic catheters, but the world is really changing with things like perimortem C-section and now the eCPR program. So you might just comment on, I guess Paramedic 2 is being run in the UK, and that'll perhaps give us some good information on adrenaline.
Right. This is the adrenaline study. I think I heard the data. The early data probably won't be out until sometime next year, but 2017 is not too far away. So hopefully we'll have some better data on the use of IV adrenaline that will bolster what is really right now a very limited amount of data on its use.
So perhaps time for one question if you've got one there.
You really broke the internet today. Lots of great questions and lots of Tarantino references from Pulp Fiction, as you can imagine, with the cardiac epi. So let me sum up a bunch of little questions that maybe you can answer at once. So if the goal is to provide perfusion, one, should we be doing low-dose epinephrine as a drip, as a continuous infusion and titrate to effect? Should we be doing noradrenaline instead? And what about vasopressin?
Okay. All great questions. And what we're looking for in cardiac arrest when we're using any of these vasopressors is again, we want some peripheral arterial vasoconstriction. So should that be by small boluses titrated, look like what we did here, versus a continuous infusion, or vasopressin? All of these are actually, wonderful potential, ways of doing this. And if you were to do it intra-aortic, I don't know which one is best because it hasn't really been studied. I played around just a little bit in some preliminary experiments with vasopressin intra-arterial. Works really well, but it was just giving, just a single dose. So that's just anecdote. It's not published, but whether it should be continuous infusion of adrenaline until you get, up to a certain coronary perfusion pressure, or small doses titrated very, very closely, I'm not sure there's a big difference. The most important thing would be is that if you're able to put in a catheter and measure the pressure, you've got something to monitor that actually is a guide to what you should do. And either way, whether it's small rapid titration doses or continuous until you hit a certain coronary perfusion pressure, either way, I think probably those might not be that different. But at least you've bumped up, you've now got a way of actually measuring the pressure and titrating to effect, something that actually, is a correlate to return to circulation.
Okay, well, we're out of time. If you could join me in thanking our speakers once again.